The very, very tough past of Strabismus work cakewalk for our audience. So I'll just go through. So this is a vast. You can, in the middle also interrupt and ask questions. So this will just run through videos quickly, not too much theory. Essentially, a lot of people discuss limbal or phonics. I don't think there is any difference long term in the outcome or your deviation corrections. But yeah, intraoperatively, you can face a little bit of a struggle if you're a beginner for phonics incisions, but it's definitely more comfortable for the patient. There are no sutures that are visible, and although it's technically difficult and tough for beginners, and has a little less exposure. I've had sometimes being called for intraoperatively with a fellow who looks like the muscle is coming in a very abnormal fashion, and then you realize they've hooked the wrong muscle because they were going through the fornix. So just be careful. That's it. So we'll talk about weakening procedures. We know that recti recessions are the most common weakening procedures that we do, and there are limits for weakening procedures. You don't want to recess more than a particular amount for that muscle, because that's going to put it beyond the arc of contact and cause severe underaction of the muscle, and a very small amount of recessions may not really give you too much effect. So these are broad limits, not necessarily, but remember, you just don't get confused with the incomitant strabismus we were talking about earlier. These are limits so that you don't have a post-op incomitance. You don't have a comitant strabismus converting to incomitance and patient starts talking about diplopia and side gazes. Those amounts of resection procedures or supramaximal were reserved for incomitant strabismus. So you have an incomitance which you can try to reduce or improve, but there was incompetence, so you can't do much about it. You can handle that with a higher amount of surgery. So I'll just go through the recession. As I mentioned, I use a fornix incision. So this is the lateral rectus. Inferolaterally, a fornix incision was made in the conjunctiva and the tenons. The muscle hook hooked an untoothed muscle hook, or the Jemiesons hooked the muscle, followed by the greens. Now we have prolapsed this lateral rectus out of that opening we had made in the inferior part of the inferior fornix. We cut a small opening above the muscle and we pass the lens hook. We identify that we have the whole muscle and we have not split the fiber, so you look for the upper pole. After that, you start your dissection. Again, variable amount depending upon how much you want to recess. One should definitely recess beyond the amount you are going to recess or resect, so that there are no residual tenons. You'll pass your sutures from here on. It's just like whatever way you were doing it for whether a fornix or a limbal. If you use one double-armed single suture, vicral 6/0 vicral, you can put one knot in the middle and then two side passes, deep bites, so that you have the posterior part of the fibers also. Again, similarly, one above. You disinsert the muscle. When you are making your mark, remember to be perpendicular to the cornea and not hold it from where you are putting the mark. So you don't want to distort the place from where you are marking. You are holding it a little away. After that, you pass your sutures, of course, very carefully, just making sure that you have the bump and you're not going full thickness through the sclera. This is in fact the area where the muscle is thinner, and if you've used two separate vicals, you're going to have two knots, one superior, one inferior, and if you of course have used one single suture, then you'll have one knot in the middle. So that's how you need to make sure that your points are equal and separate. There is no tenons or any tissue that is caught in the knot, which will contract and cause retraction. And of course, you can suture the stump, especially for the lateral rectus, because that is visible. Sometimes the patient finds that unsightly, and the fornix incision can be sutured very conveniently with an 8/0 vicral. We go on to the strengthening procedure. So you have a graded resection procedure, graded resections and plications. So these are the two recti strengthening procedures. Again, for resections, you have maximum and minimum. Minimum amount, again, you may not be very effective, but for maximum, it's important. If you go very far back, you start incorporating myofibrils in your suture, in your plication or resection, and that also weakens the muscle a little. Again, supramaximal surgeries for incomitance, we are using a longer than these amounts, but for conventional comitant strabismus, these are kind of limits I would stick to. And therefore, if you have a larger angle, you may have to do 3 muscles or do a muscle transplant procedure. So this is a resection procedure I'll be showing you. Again, and an inferotemporal fornix incision. You reach the clear sclera hook with the Jamisons. Follow that up with the greens. Make sure that you have the whole muscle. You can do a pole test that you put the pole right up to the limbus. You make sure that you have the whole muscle. You open a small opening, identify that you have the whole muscle in your hook, and then you do your dissection again to the amount you need. Definitely in resections, you need to go beyond the place from where you're going to pass your sutures. You can see the inferior oblique. You need to be careful in your dissections. You don't want to damage or cut the inferior oblique there. So again, you measure, you remember, you flatten the muscle and don't allow too much of a fold over the muscle. Otherwise, you're going to resect more than what you had planned for. So for resections, we conventionally use 2 double-armed sutures. So we have a single vicryl we've cut into 2, so, and we've attached an RD needle to both sides. So 2 double-armed sutures. You can kind of cautery those vessels anterior to where you're going to cut, so that you don't have bleeding. You cut it just anterior. You leave enough stump. And again, for the stump, you cut it as flush as possible. You're not passing your sutures through your stump, but at the base of the stump through the sclera. Otherwise, it may just cheese wire through, and you may have a recurrence or a slipped or a stretched scar or slipped muscle. So again, 2 6/0 vicryls, superior and inferior. So we have 2 sutures pulling the muscle anteriorly, so that you have again 2 knots. And that ensures that because the muscle is on a stretch post-operatively, you don't have the scar stretching or the muscle slipping posteriorly. Again, you can just close the vicryl with an 8/0 suture. We go on to plication. I have shifted virtually completely to plications instead of resections. It's cleaner, neater, less painful for both the surgeon and the patient. So the approach is going to be the same, so just at the cost of kind of repeating the same, this is a medial rectus plication that we are going to do following a lateral rectus recession. So for a resect or a recess plicate procedure, you reach the sclera, you make a pocket in the intermuscular septum, you hook the medial rectus, Jamisons followed by the Green's hook. This is the pole test. You ensure that your hook has reached the limbus, ensuring that you have all the fibers. You won't be splitting the muscle. You look at the upper pole, you make an opening in the upper pole, identify that you have the whole muscle, then you pass your Lensic through that. Again, like we are checking for that. We don't want to make a mistake, split the muscle and cause a lot of bleeding. So again, you pass your do your dissections as far back as you're going to pass your sutures. So here, I'm going to use 2 single-armed 6/0 vicryls. So 1 for the superior knot, 1 for the inferior knot. We use 2 passages through the muscles for the first round. Then we'll see this is the upper set of sutures. This is the lower set of sutures. You have to pass them well and truly through the bulk of the muscle. You don't want to have slipped or missed fibers. Theoretically, we say that it is a kind of vessel sparing, or you may not, spare the vessels, but really I would say that, you've tightened it so much, it may actually act like a tourniquet and not really give you enough vessel sparing. Now we've cleaned it just anterior to the insertion. So my suture is being passed just anterior to the insertion of the muscle. Both the sutures are now passed here. You can just see the insertion just posterior to that. Both the sutures are now passed. And we go back to the muscle. We go back to the muscle and pass our sutures again. So you have muscle, sclera, muscle attachment on both sides. Again, because in resection we had 2 loops above and 2 loops below, we have created that again so that there is good strength and there is not enough loosening. You can just push it back, or you just pull on the sutures and the extra part folds underneath the muscle. Normally, it will just fold underneath if you pull them, and therefore that unsightly knuckle we used to be worried about is no more there. You have to tightly make sure that your knot is tight, and it's because of the sclera is here, you want to make sure that it is tightly snug to the sclera. And again, so it looks almost like a resection procedure. The folded part has gone underneath. So that's what your plication procedure is. You'll close it just the way. I haven't made any significant changes in my nomograms for surgery, for resections when I move to plications, because I'm passing the suture just anterior to that. Resections are stronger. These are gross nomograms, just telling us how we can do our planning. You get 25% more effect if you operate one eye. You get about further 25% if you operate younger the children, infants, you get that much more. These are gross nomograms, which I tend to follow. There are a lot of books, different people have given different nomograms, and that's what they follow. So you can start with any, follow that up, and over time you can adjust slightly based on what you are doing. We'll just go on to inferior oblique. So we know the inferior oblique anatomy, just slight 2 millimeters above and about 10 millimeters posteriorly to the inferior margin of the lateral rectus. So we'll just see hooking of the inferior oblique. Again, inferior temporal fornix. In fact, obliques are ideally used for, they're very effective and very simple. You just go on to this, see the white sclera, hook your lateral rectus. You just place a lens hook, you lift it, and that's here your inferior oblique sitting right there, waiting to greet you. You take an untoothed hook, muscle hook, you lift the muscle, and you start seeing the posterior white intermuscular septum. So that's the important thing. That will ensure that you have the whole muscle. You can lift and check that you have the whole muscle in your hook. And even through this, the posterior intermuscular septum, you can start seeing very clearly your muscle hooks. Just make an opening. And once you put your lens hook, again, you can see clear white sclera there. And this is now your lateral rectus hooked again. You have your inferior oblique on your hook. You dissect the attachments posteriorly as well as with the lateral rectus. You disinsert your inferior oblique. It's not going to go anywhere. It's just going to sit there again, waiting to greet you. You just take out everything and you just search here. You will find your inferior oblique. It doesn't go back because it has an anterior origin as well as the Lockwood's ligament. It doesn't let you go anywhere. Now you can comfortably have your assistant hold your muscle. You can pass sutures comfortably through this. I'll just show you the things. I'll just discuss first where, so we, just like recessions, we use graded recessions, we use graded weakening procedures for the inferior oblique. So depending upon the severity, so this is 6 and 6, the original Fink's method, giving us about an 8 millimeter of recession. You can do a Park's 3 and 2, taking origin from the inferior rectus, giving you about a 10 millimeter recession. You can do a modified Elliott and Nankin, placing it right next to the inferior rectus, or an Elliott and Nankin that actually makes it a severely anterized muscle, or else you can use the inferior oblique and go nasal, making it an anterior nasal transposition, making the muscle act like a weak intortus. So I'll just show you how we measure for the Fink's and the Park. So here we have 6 millimeters and 6. So 6 millimeters, we take our insertion from the inferior insertion of the lateral rectus towards the inferior rectus and then perpendicular to the cornea. So this is the Fink's point. This is place where you're going to pass your anterior suture. This is an 8 millimeter recession of the inferior oblique. For the Parks, so this is where we are going to place our suture. I'll just show you, in fact, the 3 and 2. So 3 millimeters from the inferior rectus lateral margin insertion. This is 3 millimeters posteriorly and 2 millimeters laterally. So this is the Park's 10 millimeter recession. There is a little more effect because you are going to get a little bit of anterior, about a millimeter or so. So you can see 2 millimeters approximately and a little anterior position. So this is the Park's point I mentioned. So there is a graded recession. You can use the inferior oblique to your advantage. In fact, make it like a small intorta. The superior oblique, absolutely wonderful muscle, extremely touchy, and can be angry if you do mess with it. But extremely effective. I'll just show you the most commonly performed surgery on the superior oblique to weaken it, correcting for an A pattern, especially with superior oblique overactions. For superior oblique weakening procedures, a lot of procedures are there. Like I mentioned, the posterior tenectomy of the superior oblique, the most commonly one done. I always prefer to approach the superior oblique from the temporal margin, and this is what a PTSO actually is. We've removed the posterior. So we'll time up. I'll just show you the last video. Superior temporal incision you make in the superior temporal fornix. You go right up to the clear white sclera. it's important to make all your approaches after you see the white sclera. Otherwise, you're going to have vessel bleeding and tearing up of tissue. So you open up the posterior intermuscular septum. You hook the superior rectus in this case now. After you hook the superior rectus, you put a lens hook posteriorly, and again you'll start seeing the posterior fibers. So these are, sorry for the initial decentration, but those are the superior oblique fibers that you are seeing. So these are the pearly white. When you are hooking these fibers, go posteriorly, but rotate it a little nasally. You don't want to damage the vortex veins that are there. So there are two vortex veins at the insertion. You make sure that you have the whole muscle. You search nasally, you can see clear white sclera. Originally I used to take 2 millimeters and separate these fibers, but now I have observed that in most cases you see a curve. So these are horizontal, and then after 2 millimeters or so you can see a curve of the muscle going, tendon going. So that's where now I just arbitrarily make a separation about 2.5 millimeters, separating the anterior torsional fibers from the posterior vertical, although there is no real perfect demarcation, but that's how we'll remove. So you make sure that at least 8 millimeters or more of separation of the superior oblique fibers are done. So this is the separation that I'm doing. I cut the posterior fibers, and this is the remaining chunk of that superior oblique. It's a posterior tenectomy, so I have to remove all these posterior fibers and make sure that there is no risk of them going and sticking back onto the superior oblique. So this is that posterior window that you can see that we have created. I have removed, and these are the anterior fibers. So this is the oblique you can see going to the insertion and the cut posterior. So this is the posterior tenectomy of the superior oblique. Just to show you the outcomes, you can see the A pattern with the superior oblique bilateral, which gets corrected, and the superior oblique has been weakened enough to control the A. So thank you very much. Any questions we can just quickly take as we wind up the IC. Thank you everybody for coming.